by the torrent of scientific facts being poured into medical students' heads. After a few decades, academic leaders at some schools deliberately and thoughtfully altered the balance of science and humanism in their curricula to ensure that they were training caring and compassionate physicians. By the late 1980s, however, a revolution in biological sciences was underway. Advances in genetics and biochemistry were clarifying the molecular abnormalities responsible for human diseases, and that knowledge produced new and more effective drugs for formerly hopeless illnesses. Cancer was a perfect example. Basic biological scientists had identified genes that control cell growth, and later, medically relevant researchers showed that cancers occur when these genes are altered. Drugs directed against those alterations had remarkable efficacy against otherwise untreatable cancers. That outcome was correctly perceived as a triumph of medical research. The impact of this new science on patients convinced educators that properly educated medical students need to understand its principles. This led to a resurgence of a science-heavy pedagogy. Predictably, of course, a few decades later, the pendulum began its swing back towards humanism. Medical research itself has experienced a similar oscillation between a focus on science and a focus on patients based on two complementary but distinct approaches to solving problems. One starts when a scientist observes a biological phenomenon, such as the inheritance of physical traits from one generation to the next, and designs experiments to explain how it happens. This is the kind of basic research that produced the revolution in genetics. The other starts when a physician observes a patient, a middle-aged woman, for example, with insufficient red blood cells, tingling in her feet, and a bright red tongue, a condition known as pernicious anemia, and tries to determine if a single underlying abnormality explains her signs and symptoms. This is the kind of patient-based research that uncovered the complicated system our bodies use to absorb vitamin B12, which is needed for normal blood production and nerve function. Both types of research have had enormous impact, and both have been recognized with Nobel Prizes. David Nathan, whose life spanned most of the 20th century, witnessed firsthand the competition between these two approaches to medical education and research. Born in Boston and educated at Harvard, he started medical school during the first resurgence of humanistically focused training. At the same time, he was exposed to the practice of clinical research at legendary centers of mid-century medical science, including the Thorndike Laboratories at Boston City Hospital and the New Clinical Center at the National Institutes of Health. These settings offered Nathan models for the kind of research that begins with observing patients. He also had plenty of exposure to basic biological research, but after experiencing the patient-based approach, he was all in. Much of Nathan's career in academic medicine can be read as a continual defense of and advocacy for the kind of patient-oriented research that had appealed to him during his training. As a faculty member, then division chief, then department chair at the Harvard-affiliated Peter Bent Brigham and Boston Children's Hospitals, his own research on diseases of red blood cells followed that paradigm. All of his scientific contributions were based on observing a single patient or at most a small number of patients. He also made sure that trainees, students, residents, fellows were given opportunities to participate in that kind of research. Remarkably, he did this during an era in which basic research was ascendant. Despite the profession's shift away from patient-based research and the evaporation of government and foundation money to support it, Nathan was its tireless champion, both locally within the Harvard community and at the level of national policy. His professional life thus provides a unique vantage point from which to view the competition between these philosophies of medical education and research. But Nathan's patient-centric attitude extended beyond education and research to something even more important. As a physician, he was deeply committed to putting the patient first in all things. He spent his entire career in the milieu of teaching hospitals where, by definition, patients provide opportunities for medical education and research.